The next presentation, ההצגה האחרונה שתהיה באנגלית גם כן, ואחרי זה יהיה דיון בעברית שידבר על המחקרים האלה. זו הרצאה שאני שמעתי אותה בטוקיו של מנתח לב, רק רגע, עוד שנייה, מנתח לב ירדני במקור שחי הרבה שנים בארצות הברית, אני מקווה שבקיץ הוא יבוא בפיזית. הוא נתן הרצאה מאוד סוערת על המשמעות של המחקרים האלה על ניתוחי לב, כועס מאוד. עכשיו הוא שלח לנו את זה מוקלט, אז זה פחות, זה במשרד, זה פחות סוער, אבל המסר הוא מאוד חשוב, לכן נשמע, זה בדיוק 10 דקות, ואז יהיה את הדיון כאן על השולחן. בבקשה.
About the ischemia trial from a cardiac surgeon's perspective at the 14th Cardiac Surgery Annual Meeting at the Rambam Medical Center. I'm particularly grateful to Dr. Gil Bolotin for his invitation, and he would have been a wonderful host if this was an in-person meeting. And we look forward to that possibility in the future. The reason we're talking about ischemia today is because the 2021 HCHA SKY guidelines for coronary artery revascularization downgraded CABG to class 2B in multi-vessel coronary artery disease with normal ejection fraction. And ischemia was the cornerstone of the so-called supporting evidence to do so. The AATS and the STS objected against that, and I would refer you to this editorial for details, but also other societies, cardiovascular societies from across the globe have also sided with the AATS and STS and criticized the guidelines. Some of those organizations included cardiologists amongst them. Now, if we go back historically, the American guidelines have always given CABG class 1 recommendation with regards to survival in patients with multi-vessel coronary artery disease, regardless of the ejection fraction. And that mirrors the 2018 European guidelines in which CABG is given a class 1 recommendation in multi-vessel disease. This all changed in 2021 guidelines, where 4 references were given as supporting evidence to downgrade CABG. And let's go through them one by one. Reference number 10 is the Salim use of meta-analysis that showed that CABG is actually associated with improved survival in patients with multi-vessel coronary artery disease, regardless of the left ventricular ejection fraction. Same with the European study that showed a survival advantage in 3-vessel disease and 2-vessel disease with proximal LAD in patients with good left ventricular ejection fractions. But the writing committee of the guidelines argued that those were older studies, as if they had an expiry date, and that medical management has improved over time. We agree with that. We agree that medical management has improved with time. But what about improvements in CABG? Well, the FAME3 study that was recently published in the New England Journal of Medicine showed impeccable outcomes with CABG. CABG was effective and incredibly safe. The 30-day mortality of CABG was 3 in 1,000, identical to that of PCI. And the 1-year mortality figures were actually lower than those of PCI, but obviously the statistical significance wasn't reached. We need longer follow-up. Then we are presented with the so-called new evidence. And here's where ischemia was used as central evidence. We all know that ischemia wasn't actually designed to compare CABG versus medical therapy. In fact, not a single patient was randomized to CABG or PCI for that matter. It was a strategy trial whereby 5,179 patients with moderate or severe ischemia were randomized to an initial invasive strategy versus an initial conservative strategy. And the primary outcome was composite of cardiovascular death, myocardial infarction, or hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. The results were negative at a mean of 3.2 years, and even at extended follow-up of greater than 5 years for the primary composite outcome measure. At 3.2 years, there was the beginning of separation of the curves in favor of invasive strategy for the composite of cardiovascular death or myocardial infarction, which actually became significant after 5 years. All-cause mortality, although did not show a difference. But what's really striking about the ischemia study is that there was a 21 crossover rate to the invasive strategy over a short period of time. And only 36.2% of patients had a proximal LAD lesion of greater or equal to 50%, we as surgeons usually operate on patients with 70% or greater proximal LAD lesions. When was the last time you guys have operated on a patient that does not meet that threshold? And also, we should remember that only 23.6% of patients in the invasive arm underwent CABG. The rest were PCIs. So clearly, this is not a study comparing medical therapy versus CABG. And clearly, those are not the typical CABG population in terms of the atherosclerotic burden. And this is a demonstration of that. We looked at over 260,000 patients from the North American STS database. And in this database, and in this recent period of time, 93% of patients had multivessel coronary artery disease, plus or minus left main disease. This compares with the 69.5% in the ischemia population. And again, remember that only 36.2% had proximal LAD lesions of greater or equal 50%. These are a different animal. Those are different populations. And this is how the clinical manifestation of this difference is obvious. The STS patients are more likely to be diabetic, have hypertension, and be smoker. And they are 2 to 4 times more likely to have cerebrovascular disease, peripheral vascular disease, or heart failure. So there's really little overlap between the ischemia population and the CABG population. I don't know what time it is right now where you are, but if this is lunchtime, this picture does not help. The final fourth reference supporting the downgrade of CABG was actually a meta-analysis of 14 randomized trials. But those trials excluded patients with heavy atherosclerotic burden, and many of them were PCIs in terms of intervention rather than CABG. In fact, half those studies did not even include a CABG arm, and the follow-up was brief, 4.8 years. When we offer CABG, we offer a lifetime therapy. We're not looking at 5 years. We're not looking at 7 years. We're looking at decades. So in summary, the four so-called supporting studies, 2 of them clearly demonstrated survival advantage for CABG, but they were deemed old. And the 2 newer studies, including ischemia, were really not the kind of populations that we usually offer CABG to. And they did not really were designed in the first place to compare CABG versus medical therapy. So they really provide no meaningful evidence. And what we feel is the problem here is that the guidelines keep focusing on the ischemia-like population, where there's a low atherosclerotic burden, low event rate, and very short follow-up, unlikely to see a benefit for any kind of intervention. What we really need to look at is this end of the spectrum, the heavy atherosclerotic burden, the high event rates, and the longer follow-up. So any correlation between evidence or ischemia and the CABG recommendations in the guidelines, in the recent guidelines, really is a forced correlation. What the new evidence, including ischemia, supports is that it is reasonable in patients with stable coronary arteries, normal ejection fraction, and low to moderate atherosclerotic burden, such as the ischemia patients, a strategy of initial medical therapy and close follow-up with revascularization as a future option. That is a reasonable strategy. So nobody talks about the downgrade of CABG, and death and adverse events have been well documented in patients awaiting CABG. In addition, there's increased risk of CABG if you wait and let the ejection fraction drop, or if you go in as an emergency. Both are potential byproducts of unwise deferral of CABG when indicated. This is an example of a patient who had 3 vessel coronary artery disease, normal EF, and was treated medically because of ischemia. And guess what happened? He sustained a massive anterior infarct and really dropped his EF down to 25% and has this huge LV thrombus. Clearly, this patient has not received the best possible care. The prognosis was negatively impacted. Unlike this patient who's 88 years old, who 30 years ago underwent CABG for 3 vessel coronary artery disease with normal ejection fraction. And if you look, his right coronary and left coronary are totally occluded. This patient is not living because of optimal medical therapy. This patient is living because of a patent lima to LAD that supplies the entire heart through collaterals. So the next time you see a patient with 3 vessel disease and normal EF, ask him or her, is your priority to live longer? And if so, then cabbage is the way to go. In conclusion, medical therapy is the cornerstone therapy. It's an important therapy for all patients with coronary heart disease. And evidence supports the safety of initial medical management in select patients, especially those with low atherosclerotic burden. But cabbage is the most effective and safe and durable intervention that we could offer those patients. And I would refer you to this editorial that I published with my colleagues in JAMA Surgery for further details. Thank you very much for the huge privilege and honor. I appreciate it.